lecture series we're covering now is a discussion of the development of the respiratory system. We had earlier discussions about the development of the face region, the pharyngeal or branchial arches coming forward to fuse in the midline, finalizing the formation of the respiratory system, basically the nasal cavity and the nose. I know there's additional prominences, as you know, related to the formation of the nose and the complete formation of the oral cavity. We recall the location of the buccopharyngeal membrane way back at the base of the tongue, where the pharyngeal arches are, our pharyngeal tonsils are there. And the discussion we're having now is development of the foregut region, basically from that buccopharyngeal membrane back down in through the forming chest cavity and some of the outgrowths of the endodermal cells along the length of that structure, basically the upper esophagus junction with the pharynx that has formed in this area from the foregut. And this area of the foregut really has formed from the cardiogenic region, folding into the chest, as we recall. The diaphragm had formed. The heart was placed within the chest cavity. That U-shaped extraembryonic coelom had been reshaped along its margins by structures growing within the different areas. And we recall that it formed the the pericardial sac and the pericardio-peritoneal canal, and we'll see this pericardio-peritoneal canal being invaded basically now by the growing lung or respiratory system, let's say, and reshaped to form the pleural cavity. The lecture before this one covered that in a bit of detail, all the branching of the pulmonary system, and we'll see some more of that in today's lecture. So one of the focuses for today is a discussion of the lungs and the bronchi. We recall the adult structures. There's primary, secondary, tertiary bronchi, and then on to bronchioles, and then few more branches before finally getting to the alveoli. And we recall that the alveoli are these blind end sacs that have on the atmospheric side a simple squamous epithelium, this thin layer of cells. And the cells are of two types, the type 1 and the type 2 cells, and we'll go into the details of those in a bit later on another slide. Recall that the mesenchymal cells would be growing on the other side and differentiating into all the structures, the connective tissue and the vasculature. Of course, the nerves would have grown into this area, the lymphatics, and I think I mentioned the connective tissue cells. And the objective here is the same as when we talked about the formation of the chorion, where we start with many cells separating blood and, of course, it's amniotic fluid, but anyway, the future atmospheric space within the alveoli, and eventually that's just going to thin out and thin down to a very small dimension membrane system with some extracellular matrix in between so that we can have the diffusion of the gases. So this is the ultimate endpoint of the development of these outgrowing caps of cells. I'll call them caps of cells on a cylinder that's growing in. They're not a solid core. It's really a cylinder, and on the tip of the cylinder growing in are rapidly dividing cells, basically to infiltrate the mesenchyme in that area surrounding the pericardio-peritoneal canal and to differentiate into things. So this is what we're shooting for, to get an open passageway all the way down to that thin respiratory membrane. So the lung buds are first going to divide into two bronchial buds. So we're picturing somewhere in basically the embryonic neck region in the foregut, and there's going to be these endodermal cells growing, forming these columns, and then finally a cylinder of cells that are going to push out, branch first, well, after forming the trachea, branch, form the bronchi, and then continue to go on to branch. So the first branch is the primordial trachea, of course, and we know that that splits into the two primary bronchi, right and left, and that's what these bronchial buds represent. So these bronchial buds are going to grow laterally into the pericardial peritoneal canals, forming the pleural cavity as this proceeds. So let's follow through with a few illustrations that help us to visualize this a little bit better than me just shouting out words. First, we orient. This, of course, is a lateral view of the embryo. It's a 5-week embryo. So just 2 weeks after we formed the three-layer, 3-week embryo, so things happen very rapidly. And we orient to the pharynx. We can see some of the pharyngeal arches. And as we're looking at the foregut in this area, basically highlighting the endoderm lining this region, we see the pouches in between the arches, and we've studied those in the formation of various structures in the face, head, and neck region. Now we continue down below the pharynx, where the foregut is continuing to develop, and we can see the early trachea and the two bronchial buds that we had mentioned in that 5-week time period. We orient to this bulge on the surface. We know that this is the cardiac bulge, with the liver bulge being produced just below it. So the liver is already developing at this time. We can see the midgut and the hindgut forming as well, the cloaca and the cloacal membrane back here. This would be the allantoic stalk to the allantois, and this would be the vitelline stalk, as we know. So very characteristic appearance. Of course, we'll study the digestive system in more detail later. Now we're focusing on the upper part of the digestive system that is branching off to form the early upper respiratory system. And the initial bud is, of course, called the laryngotracheal bud. It's coming from the larynx. Its site of origin is going to differentiate into the larynx, and it's going to extend to become the trachea, and thereby divide into the bronchial buds to contribute to the formation of the bronchial tree. So now basically we have, at a slightly later stage, a cross-section or transverse section through this chest region, primordial chest region. We use our same orientation procedures as we always have. The neural tube telling us that this is dorsal. It's closed off already, the surface epithelium there. We see the appearance of a somite, things beginning to happen in the tissue here. Obviously, the forelimb bud in this area. These would be vascular structures here. We always oriented to vascular structures immediately ventral to the forming spinal cord. We see a dorsal mesentery for this general area here that continues down all the way to an attachment to the heart, the dorsal mesocardium. And we see the lung buds, let me just refer to them this way, here, pushing into the mesenchyme in this, what would be originally called the dorsal mesocardium. So I had said that the heart, the cardiac region, rotates down into the chest region. In doing so, it picks up that dorsal mesocardium and becomes associated with a lot of mesenchyme in this area, twisting the original pericardial peritoneal canal from a horseshoe shape into a bent horseshoe shape, and the pleural pericardial opening and the canal runs through this area where the horseshoe got bent, as we recall. So the lung buds growing into this mesocardium, into this mesenchyme of the dorsal mesocardium, obviously is going to expand this collection of cells and produce a bulge into the pleuropericardial canal in this area and begin to close things off. We remember the pleuropericardial process here, or fold, that is also going to come in and contribute to the separation of the pericardium from the pleural cavity. So already we can begin to see the pleural cavity right in this area here, where the pleuropericardial canal is, that portion of the pericardio-peritoneal canal originally. And so it's getting reformed and reshaped into an area that ultimately is going to become flattened so that there isn't much space there, as we know, for any one of these body cavities. And the two layers, this layer on the surface of the lungs is going to become thinner, and it will also approximate the layer on the body wall. So we can already see the early signs of the visceral pleura on the lungs here, the lung buds, continuing on at some point with the parietal pleura on the body wall within the chest cavity. And it will ultimately be separated completely from the pericardium. Thus we can proceed excuse me, to this view of the late embryo. We see that there is an apparent distension in this area. This, of course, would be the combination heart and lung bulge contributing to the swelling-like appearance here, I guess. And what we can see is a light bluish coloration from this type of image of the pulmonary system at this time. So we can see the trachea has formed, and many branches of the bronchial tree have already formed, and even the rib cage has already formed. So we zoom forward very quickly in this, and we know that set of lungs is separated on the front side. We're looking obviously from the dorsal view. From an anterior view or a lateral view, we would see that the heart, which is very likely this structure right here, is completely separated from the lungs now, as we know they are in the adult situation. As the lungs continue to grow, we know they're going to occupy more space and basically overlap on the anterior surface of the heart, just to some degree, not completely. As seen in this superior view of a transverse section of the adult human, the lungs will eventually have this projection anteriorly. They don't overlap on the anterior surface of the heart completely, but obviously that dorsal mesocardium disappears, all except for the tissue that's surrounding the great vessels that penetrate through the pericardial sac to be attached to the heart, or in the other sense, to penetrate the pericardial sac from their attachment to the heart to be distributed to the rest of the body. So from the superior view, we can see first the spinal cord getting our dorsal orientation. The somites obviously are going to differentiate into virtually all the tissue that we see here. The mesenchyme definitely into the skeletal system observed here with the vertebra. Immediately anterior to the vertebra in this area, we looked for the vascular system. We can see, of course, the aorta here and some other vascular branches. And that ultimately is pushed off to the side a little bit, and the esophagus lies here posteriorly. So the esophagus is going to continue down, obviously, into the abdominal cavity. That portion of the foregut that forms the esophagus stays in the most posterior position in the thoracic cavity. We see the two primary bronchi the left and the right dividing, and going off to continue to divide seemingly endlessly, as we will view in a moment. This slide is also showing us the dark blue layer on the surface of the lungs, as well on the surface of the heart, and then the layer that it is continuous with here for the lungs onto the body wall of the chest, and of course also reflected onto the parietal layer of the pericardium, as we had said. So they don't really fuse, they just overlap each other. And obviously this is the pleura, the visceral pleura on the surface of the lung that developed, because the lung grew into the mesenchyme in this area, and eventually the mesenchyme thinned down so that there's just a simple squamous epithelium lining the outer surface of the lungs. So it's one cell layer thick with a little bit of loose connective tissue under it, called a mesothelium, or a serosal membrane, secreting serosal fluid into the pleural sac or cavity here. We should call it cavity because the sac is the two layers of the pleura that create the container, right? Stick your hand in a sac that's in the cavity, and then the paper bag is the sac that contains it. So the pleural sac is made up of the visceral pleura and the parietal pleura. As well, the pericardial cavity is surrounded by the pericardial sac with the visceral pericardium on the heart and the parietal pericardium lining the body cavities. So we can picture now this being the adult version of this. So the lung buds grow in, continue to expand. The ratio of actual lung epithelial tissue and bronchiolar tissue, the air passageway tissue, to the mesenchyme decrease, so things are going to thin out, and we know that we need that to happen. And the dorsal mesocardium will go away, except where it's reflected onto the major vessels of the heart, and the heart will be suspended within its separate pericardial sac, and the lungs within the pleural sac in the chest region. So the layer of the visceral pleura is acquired from the splanchnic mesenchyme. So splanchnic meaning viscera, so it's going to be the mesenchyme that will form the surface layer of the viscera or the organs, such as the lungs. But the parietal pleura is forming, it's lining the body wall, so that's going to form from the somatic mesoderm. So if we go back, this would be visceral mesoderm, within which the lung buds are extending and growing. And this would be somatic mesoderm out here, forming the parietal pleura, and then the visceral pleura forming from the splanchnic mesenchyme. Well, now if we take an illustrative view of this, say an anterior view, this is an anterior view, right side here. The right primary bronchus is more vertical. The left is less vertical, obviously, because the heart becomes displaced to the left, and it keeps that lung bud from growing straight down, so it has to be deflected a little bit more horizontally. And so you can always tell the difference between right and left based upon that orientation. And this persists into adulthood, and most aspiration pneumonias, aspiration suffocations, still one of the major natural causes for death in geriatric patients. It will be related to things getting stuck in or obstructing the right primary bronchus, because they get breathed in and just go right straight down into there. So let's get oriented. We see this pinkish red structure, slightly redder on the inner surface layer. That's obviously the somatic mesoderm that we had mentioned that differentiates into the parietal pleura. Then we see the trachea and the lung buds, bronchial buds, have grown into the splanchnic mesoderm, what we were referring to as the dorsal mesocardium. And this splanchnic mesoderm obviously is going to thin out over time. It's not just going to disappear, a lot of it's going to differentiate into any of the connective tissue lining and the vasculature lining the trachea and the bronchi and bronchioles and alveoli. So it doesn't just go away and disappear, finally differentiates into its terminal cell type, and shifts over to functional activity rather than mitotic division and differentiation. So the view that we're looking back at back a couple of slides was a transverse section through this area here, and we're looking down from the top, as you recall. And this is an illustration. The other was illustrative as well, but of the actual embryo. Well, now we can take a look from the superior view, where there's a horizontal section through the dorsal mesentery, they're calling it. We had referred to it in the chest region here, near the heart, which we can't really see in this slide. We're calling this the dorsal mesocardium. So the lung buds have grown into this area. This is obviously a bit more advanced. And we see how they are creating this protrusion into the pleuroperitoneal opening and the canal through this area. We see the liver bud on either side. Since this is a dorsal view and we're looking from therefore looking from the top down, right is right and left is left. So here's the right lung and the left lung. We already see the left lung displaced a little bit farther laterally than the right lung. That's because the heart is somewhere there in front of all of this. And so we see the liver on both sides right now, and one of the first things we should be saying, well, isn't the liver on the left side and the stomach's on the right side? Yes, it is in the adult, but at this stage, the gut tube, the foregut in this area that's going to form the stomach, is still running directly vertically, so the liver is split on both sides. Eventually, the stomach is going to be displaced over here to the right side, and then the liver will shift to the left side as the body cavity enlarges as well. So there's not enough room for everything at this point, and as we'll see, this ends up compromising the amount of space in the abdominal cavity, and the developing gut will herniate into the umbilical cord because there just isn't space, and then ultimately it comes back in when the embryo and fetus get big enough for things to all fit in. So it's very easy to see now the splanchnic mesoderm here being continuous under the surface layer of cells, that future mesothelium, the visceral pleura. It would be differentiating into that visceral pleura, and it's continuous in its reflection onto the layer created by the somatic mesoderm, or mesenchyme, I should correct that term at this point. We're using mesenchyme. It's more further along in its differentiation. So the parietal pleura, would be forming over here from the somatic mesoderm. And the caps of endodermal cells, those caps of endodermal cells, at the end of that cylinder growing in, they continue to divide, and they don't form a solid core of cells. They actually separate from each other as they're growing, so they leave an opening, and it'll be important to keep that in mind as we proceed to looking at some histological samples of the developing lung tissue. This growing cap of cells will be solid at first and then move away from each other and leave an opening in the center, so it's a cylinder. But another thing will be happening is the walls will be a little bit thicker, and then ultimately everything will differentiate into what it's supposed to be, so the thickness of the walls will decrease, as we will see. So again, this is the anterior view in that illustration. So the primary bronchi divide into the secondary bronchi, then the tertiary bronchi and quaternary bronchi, ultimately bronchioles, terminal bronchioles, alveolar ducts, and alveoli. So at first we don't have any alveoli. We don't even have the thinning between the vasculature and the endodermal cells that will form those type 1 and type 2 alveolar epithelial cells. Still just these cylindrical columns of cells pushing into the splanchnic mesoderm in this dorsal mesentery, or mesocardium as we called it before. Until ultimately the full set of lungs will be produced as seen here. As the lungs develop, along with all the other related structures, the body wall, the chest wall, the liver and the stomach and the diaphragm inferiorly, and of course the heart there in the front off to the left a little bit. So the lungs conform to the space that they're provided. And we can see that happens very early, especially from this supero-posterior view. You can see the curvature, the concavity of the posterior surface of the lungs initially, and from an inferior view here below, the right lung being a bit larger, and we can just about see the concavity of the surface there pushing inward, and the left lung a little bit behind in its development because of the displacement by the heart. So we can see the trachea is fully formed, and the primary bronchi branch from that directly into the lung. So this point where these structures enter the lung is called the hilus. So there really isn't a hilus at the beginning, because there's just the solid splanchnic mesenchyme in this area, and we have these cylindrical columns of cells growing in. Ultimately, all this thins out, and these two primary bronchi coming off the trachea, of course, will extend for a period before they are completely surrounded by the alveolar lung tissue of the upper lobes of the lungs. So that ultimately there is a short portion of the primary bronchi that is not completely surrounded by the actual lung tissue. This can take us then to a view of the adult. Obviously this is an anterior view. We can see the heart on the anterior portion in the middle of the chest cavity. It's called the mediastinum, in the center of the sternal area, if you want to think of it that way, and slightly off to the left side, therefore leaving the full right portion, full right hemithorax, if you will, available for the right lung to develop, and we know it develops the 3 lobes, and it's even a little more complex than that, as we will see once we dig in internally. However, because of the heart on the left side, the left lung only develops the 2 lobes, upper and lower, but each of those lobes develops a little bit differently as far as being segmented internally. Before going to the body wall for the pleural cavity, I'll draw your attention to the medial surface of the left lung, and we can see the aortic impression in here, and there's also the cardiac impression. So as I said, whatever space is available, the lungs are going to grow into it. They don't compromise the other organs there. They just grow in and take full advantage of all the space that's available. Now we can draw our attention to this upper right panel, and we see that this is an enlargement of an area near a rib. So we obviously have the rib and the intercostal muscles and the neurovascular bundle, the intercostal neurovascular bundle. There's one layer that isn't shown here. There's an endothoracic fascia, a very thick fascia, just deep to the intercostal muscles and the ribs, the costa. And on the inner surface of that endothoracic fascia will be that simple squamous epithelium with just a little bit of loose connective tissue under it, the parietal pleura, lining the body wall. And I make that point because the real thick part of this white line shown here really should represent that dense, irregular connective tissue, the endothoracic fascia. And as we know, there has to be some containment of the thoracic cavity so that we can produce the negative pressures. If something penetrates all the way through the intercostal space here and the endothoracic fascia and breaks through the parietal pleura, which isn't very difficult, a little bit of loose connective tissue in a single layer of cells, then pneumothorax will occur as air enters the pleural sac, and the pleural sac has the cavity here that is between the parietal pleura and the visceral pleura that is lining the lungs. So this layer lining the surface of the lungs is called the visceral pleura, and it differentiates from the splanchnic mesenchyme. And this layer out here, the parietal pleura, differentiates from the somatic mesenchyme, as does the endothoracic fascia. Then to summarize a bit and catch up on things, by week 5 the right and left primary bronchi are formed. So we obviously had progressed all the way from embryonic to fetal stages, especially the stage where we saw the full pulmonary system in that reconstructed MRI image. So in 2 weeks after we just have 3 cell layers, we have the primary bronchi formed. The right bronchus is going to be larger and more vertical. They divide into the secondary and tertiary bronchi to form the lung segments that we'll discuss in just a moment. Also, remember, there's cartilaginous plates and smooth muscle associated with not just the trachea, but the bronchi and bronchioles. And cartilage is connective tissue, and any muscle tissue differentiate from mesodermal origin, this time splanchnic mesenchymal cells, as we had mentioned before. So the epithelial lining, the respiratory epithelium lining the trachea and bronchi, bronchioles, alveolar ducts, and the alveoli are of endodermal origin. Everything else plastered on the outside of them, connective tissue, such as the cartilage, and just connective tissue like collagen and elastic fibers that originate from fibroblasts, and any smooth muscle, and the vasculature are going to differentiate from the splanchnic mesenchyme that the laryngotracheal tube grew into originally and continued to branch through the bronchial buds at 28 days. And then here at 35 days, we see the secondary bronchi forming. Then by 42 days, we're already seeing the segments, the appearance of the lobes of the lungs, the right with 3 and the left with only the 2 lobes, upper and lower. But obviously, they're continuing to grow and develop and divide until there will even be segments that will form. So A in this image is the right upper or superior lobe. B, of course, is the right middle lobe. C is the right lower or inferior lobe. And then obviously D is the left upper lobe, and E is the left inferior or lower lobe. So 3 lobes on the right and 2 lobes on the left. And then it continues to divide from there to a level that becomes more bothersome for memorization than anything else, if you will. But obviously we see it becomes very ornate, dividing down to smaller and smaller diameters. And of course, when you study respiratory physiology, it's very important to have this division, because the more divisions you have, the more alveoli you can have. The more alveoli you have, the more surface area you have for gas exchange. You also can overcome the resistance of airflow through these mechanisms by having a total volume of space for air to move. This is reflecting that, this image is of course reflecting that continued growth and development and division of the lung tissue and into the segments. So the right superior lobe is going to have 3 segments. The right middle lobe will have the 2 segments, and the right inferior lobe will have 5 segments. And this becomes important clinically because there can be segmental problems of fluid accumulation, which typically isn't dealt with too much surgically, but certainly with tumors, whether they originate in the lungs or metastasize there, it is possible just to remove a segment of a lung, of a lobe of a lung, because the mesenchyme, the splanchnic mesenchyme, forms a complete connective tissue containment of each segment. So they can be separated and pulled out just as a segment, and the rest of the segment of the lobe can remain. As well, of course, the lobes can be removed if necessary. The left side is different, of course. There's a left upper lobe, as we had said. It has 4 segments, and the lower lobe on the left has the same number as on the right, the 5 segments. And here we see this in a transparent illustration of the lung tissue. The trachea, we see the tracheal rings from the splanchnic mesenchyme, primary bronchi meeting the lung tissue at the hilus of the lung. Remember, the neurovascular bundles are going to enter here as well, and branching into secondary bronchi for the upper and lower lobe, and then tertiary and quaternary branching to distribute to the different segments. Same with the right side, as we had seen before. Then let's consider the lung maturation, since we have this appreciation for the extensive branching of the air passageways, the upper and the lower respiratory tracts, to get the atmospheric air into the deepest part of the lungs. And of course, it's all amniotic fluid that's within these. They're not empty spaces filled with air. They're filled with amniotic fluid. And very early on, the skeletal musculature of the chest and the diaphragm begin to function, and the chest movements, and as well the beating of the heart help to move fluid in and out of these cylindrical tubes growing into this dorsal mesocardium, so that there is some movement within them, contributing to keeping them open and thinning out and infiltrating into this area. It's not all mechanical. I'm not trying to pretend that. There's still that magical thing of how cells know where to go and what to do to make what they're supposed to make. But the coordination of the neuromuscular system with the tubular system for the flow in and out begins very early. So all the major structural components of the lungs will be complete by week 17, but obviously respiration isn't possible yet. By week 25, the immature alveoli are formed. The mature ones are formed postnatally, and the lung is vascularized. The mesenchyme is differentiating into the vasculature as all of this is happening. The viability is possible but slim at 25 weeks. That's pretty much the cutoff for premature neonates. And the blood-air barrier is later established with the alveoli lined by that type 1 and type 2 alveolar cells. So the stages of development of the functional aspect, the gas exchange in the lung tissue, are in a set of 3. There's a first, second, and third phase. The first is called pseudoglandular phase, so 5 to 17 weeks is when this is occurring. And it resembles an exocrine gland, so these ingrowing cylinders kind of look like the ducts of an exocrine gland, maybe the pancreas or a salivary gland. So their walls are kind of thick. and they've got an open-ended sac at the tips of them. They're growth points, if you want. Well, this is going to proceed to another phase, a canalicular phase. Obviously, things are going to get a little smaller. Things are going to begin to thin out a little bit. And this is where the bronchioli will continue to divide into the smaller canals and be vascularized steadily. Then finally, the third phase is the terminal sac period. And this is from the beginning of the 7th month. So the cuboidal lining of the bronchioli change into the thin flat cells. So we have tall columnar pseudostratified epithelium in the upper air passages. As you get farther and farther down and closer to the alveoli, they're not so tall. They become shorter until they're just flat cells, as in the alveoli. So this cytological change has to occur over the development of the lung tissue, so that at birth, here we're talking about the 7th month, so within a month or month and a half, got to be ready to have everything you need to differentiate finally into a functional alveolus with that first slap on the buttocks. So let's take a look at some illustrations, and we'll look at some histological slides. So this diagram is a sketch of the histological sections we'll take a look at, these progressive stages. So in panel A, this is the pseudoglandular period. So we see there's a lot of vasculature, a lot of little blue star-shaped splanchnic mesenchymal cells in this area. So as I said, eventually the ratio of the endodermal cells to the mesenchymal cells, the volume occupied by each is going to reduce so that they're nearly equivalent, and we end up with a thin interface between the endodermal cells, ultimately becoming simple squamous cells, and the vasculature. And all the other connective tissue components will be added on by these mesenchymal cells. So rather than being all stretched out, they'll kind of retract a little bit and turn into a fibroblast or a chondroblast, and start laying down the extracellular matrix, the collagen, elastin, and of course the cartilage. The canalicular period is the point where there's a greater extension of these cylindrical columns, so they begin to take on a canal-like appearance as the secondary and tertiary bronchi and bronchioles especially begin to develop. So the terminal bronchioles are going to develop at the end of the bronchi, quaternary or tertiary. What comes after that? Quaternary or the fivenary? Pentanary, is that? Branches. That'd be the finest bronchiole, so there'd still be some smooth muscle and cartilage. Then it's called respiratory bronchioles that lead into the terminal sacs that will ultimately become the alveoli. The terminal sac period is where there's well-established terminal sacs and a thinning of the respiratory membrane. They finally have the contact of the endodermal cells with the developing endothelial cells of the vasculature, and the formation of the alveoli is prominent. We can see the star-shaped mesenchymal cells are still present, and they're beginning to make contact with the surface of the endodermal cells. Some fibers are represented in here, elastic fibers, collagen fibers. Some of them are going to differentiate into chondroblasts so that they can lay down the cartilage. And then the alveolar period, birth to 8 years, is where the alveoli are going to take on the characteristic appearance that we're more accustomed to seeing in the adults. So we see in this view a smooth muscle cell developing here. They're not really showing any cartilage yet, but the mesenchymal cells are differentiated into fibroblasts, and they're laying down the extracellular fibers and amorphous types of connective tissue. And where there's cartilage, there would be a chondroblast, collections of chondroblasts that are laying down the cartilage. Thus, we had followed the branching of the air passage in as deep as we could. Then finally, there's the outpocketing on the terminal bronchioli, and then even more so on the respiratory bronchioli, before finally there's just the grape-like clustering out pockets of the alveoli to form the alveolar sacs, as we are most familiar with them. And in a routine paraffin section, we see this branching to a respiratory bronchiole. So a terminal bronchiole here, a respiratory bronchiole, very thin epithelial lining on them, the dark blue line, and then the rest of this is extracellular matrix, the connective tissue, and vasculature, the larger vasculature. And the alveolar duct will lead just into this massive collection of alveolar sacs. If we look down into an alveolar sac, first we see where some of them come together, so that splenic mesoderm has become minimized. We now see the vascular bundle in here. Of course, there's artery side. Well, basically it's capillary at this point, as we know. Between the arterial and the venous sides, there's connective tissue. If there's any stretch receptors, any smooth muscle, the nerves to innervate that, and so on and so forth. Lining the alveolus are those thin type 1 alveolar cells, especially where there's the contact with the vasculature. And the type 2 are the surfactant secreting cells, and of course the surfactant is essential for preventing the collapse of the alveoli, reducing surface tension. There will be macrophage that will infiltrate from the vasculature, but that's no need for us to be concerned about right now. If we zoom in on the junction of an alveolus and a capillary, we see that the extracellular matrix is minimized basically to the basal lamina of the type 1 alveolar cell and the endothelial cell, so it's nice and thin for the diffusion of the gases. Now we'll just go through the histological sections. This is the pseudoglandular period, so we can see there's just all these rather uniform sized branches with a lot of mesenchymal cells around. Looks a lot like a gland. If you haven't studied histology, I know it's kind of hard to realize that, but this is what a gland would look like, a bunch of glandular cells and the ducts leading out, but it isn't, of course. These are the splenic mesenchymal cells, and these are the ingrowing bronchi, bronchiole buds, and some primordia of alveoli. The canalicular period, we can see that there's more branching and somewhat of a thinning of the walls. The respiratory bronchioli, here's a bronchus with a taller epithelial lining. This is week 16, so about week 16 to 25 is when this is occurring. The canalicular period can have another appearance that still seems like there's a lot of mesenchyme around it, but there's a lot of branching that you can see of these structures. And then finally, the terminal sac period at 24 weeks. And we see that there's a thinning of the endodermal cells in the area of an alveolar duct. We can see a larger vessel here with red blood cells in it. And the epithelium is a little bit thicker on this part up here, cuboidal epithelium, where the respiratory bronchiole meets up with the alveolar duct leading into what ultimately, right now they're called the terminal sacs, but ultimately they will develop into the alveolar sacs. So finally, in the last few seconds, of course, with lung maturation, the surfactant must be produced for the lungs to function normally. They're produced by the type 2 cells, as we saw, and if it isn't being secreted sufficiently, there will be respiratory distress, especially in a premature infant, obviously. The adequate respiration is also requires the appropriate pulmonary circulation, so any problem with that, and there's problems. The fetus practices breathing movements, as I had stated. The fluid in the lungs is necessary for the development, but of course it must be cleared at birth so that air can flow. So it provides thoracic pressure during delivery, and cleared by the thoracic pressure, the transfer into the pulmonary vasculature, and the remainder is physically aspirated, as you know. So ultimately, we want highly vascularized. Here you can see a scanning electron micrograph colorized of the rich capillary beds overlying the alveolar sacs. and the surfactant working so that we can have the transfer of the gases between the capillary bed and the atmosphere within the alveoli. So the remainder of this focuses on the defects, and hopefully you can understand that relatively well on your own. That is also covered on the posted recorded lecture from prior semester. Appreciate your time and attention. Have a good weekend. Have a great spring break, right? And we'll see you all in what? A week from Monday, right? Bye-bye.